It is just a huge honor for me today to be podcast interviewing Dr. Donald Avery Curtis, DMD, FACP. He is a professor in the Department of Preventive and Restorative Dental Sciences at UCSF. That's University of California, San Francisco for you international guys. He is a board certified and past president of the Pacific Coast Society for Prosthodontics and American Board of Prosthodontics. He has published in Head and Neck Bone, Journal of Biomechanics, and numerous basic science, medical, and education journals. His current research is focused on clinical judgment and professional development. With recent invited editorials in medical education, IJOMI and JADA, Dr. Curtis received his DMD in 1981 from the University of Oregon, certificates in prosthodontics from the University of Southern California, and maxillofacial prosthodontics from UCLA. And I wanted to get him on the show today to talk about how we assess implant risk to a patient, and more importantly, that science is a data-driven institution and how we need to be more data-driven instead of intuition-driven. But my first question for you is, you got a certificate in prosthodontics from USC and maxillofacial prosthodontics from UCLA. So basically what you're saying is USC didn't cover everything and you had to go back to UCLA, so UCLA is a better school. That's what I'm hearing.
Yeah, well, pretty much. I just didn't want to enter the real world. You know, the longer I could stay in education, the safer it was. And private practice is tough, and we have to make tough decisions in private practice. And so I think early in my career, I avoided that by staying in school. But no, I benefited from a lot of great public institutions and a few private ones. And it's fun to be here on the show today.
Hey, is there a difference though? I mean, is there a difference between going to USC in prosthodontics and versus UCLA maxillofacial prosthodontics? Is the distinction of maxillofacial make it different somehow?
Yeah, prosthodontic training includes now a 3-year. When I was in training, it was a 2-year training program. And that is on implant placement, on implant restoration. It's on crowns, bridges, dentures, aesthetics, and sometimes with and sometimes without a master's program. Once you're done with that, the second tier possibility is to do maxillofacial prosthetics. It's just treating and managing patients with acquired and congenital defects of the head and neck. A lot of automobile accident patients. 4% of all cancers are head and neck, when it affects part of the upper or lower jaw, and 1% of all cancers are maxillary sinus. So you take out the maxilla, you need a prosthesis. And so a maxillofacial prosthodontist is the step after regular prosthodontic training, and those are the types of patients we see. So UCLA had a guy named John Bumer, probably the best in the world.
What was his name?
John Bumer. And he actually wrote a book with my dad. So we're getting legs with his story. But my dad was his mentor and he was my mentor. And that was kind of fun, actually, for me. So I was down there in the mid-'80s at USC and then UCLA. And then I came up and I was in private practice in Berkeley for 30 plus years. And I'm had a joint appointment over at UCSF. And now I'm focusing more on activities at UCSF and less private practice, but still seeing patients at UC.
And for you international students, he went to Berkeley, so that means he's officially a hippie. I think that's fair to say, right? I can tell by the hair thing you got going. You got to be a hippie if you're from Berkeley. So that is so cool about John. So your dad is a prosthodontist, and so his mentor was John Bumer, professor emeritus at UCLA, and your dad was his student.
Well, my dad was his mentor, and John Bumer was my mentor. So it kind of flip flopped. So
wow. And what was your dad's name?
Thomas A. Curtis.
Wow, what a small world. And Unbelievable. So take us through your journey about the JADA. I posted that article on Dental Town. How should we communicate implant treatment risk to a patient by Donald A. Curtis, DMD, which is you, and Stephen J. Sadowski. And my gosh, it's exploded on Dental Town. Everybody's talking about that. And what I liked also about it is you had a link called My Dental Risk. And I tried to fill it out, but I couldn't because the first question says, "Do you smoke?" But it doesn't say, "Smoke what?" No, I'm just kidding. But so talk us about your journal about the writing that article, and it seemed to be a very impactful article.
Yeah. Um, the idea behind it is that while patients are pretty aware of their potential risks for cavities, for periodontal disease, in the lay literature, in social media, they're pretty aware that if they don't brush their teeth much, if they eat a lot of sweets, they're going to get cavities. They're pretty aware that they can get periodontal disease and what the consequences are. There's a number of recent studies that show patients are not aware of the potential to lose a dental implant. In fact, a very high percentage of people who have dental implants, who have gone through the communications with their dental care provider, think that their implants are life lasting, almost 75%. And while that is true for some patients in low risk groups, it's not true for all patients. And so patients are aware that they can lose their teeth, but not aware they can lose their implants, basically. And so this article was about that and how to communicate the fact that there's biologics uncertainty in pretty much everything we do, including dental implants, and probably especially in dental implants. That the reality is that there's much more risk associated with dental implants than people realize, than patients realize. And we need to kind of ground ourselves and ground the patient into what those risks and what their responsibilities are so that they can work optimally as is possible given, the risks the patient presents with. So I think a couple parts. So one, patients aren't aware. The other part of that article that I think is important is we're probably not as objective in our decision making as we think we are. That we like to think, and we teach UC that we need to make decisions that are evidence-based, that are grounded in science. And we use that as a resource to inform our patients and steer them in the right direction. But, and I don't think I quoted the author on this, but there's a few people that would say we're probably not as good at decision-making in complex systems as we think we are. So there's this guy named Kahneman, who many of you have probably heard of. He wrote the best-selling book, Thinking Fast, Thinking Slow. And he's won the Nobel Peace Prize, and he's won all sorts of presidential awards and recognitions, probably the most famous psychologist of the last 100 years. And what he wrote in his stuff was that when we're confronted with a complex decision in a complex environment, and healthcare decision-making is really complex, we tend to simplify and minimize peripheral input. In other words, when we're making a decision on whether to do implants or a bridge or a partial denture, we don't leave the door open for considering all the relevant variables as long as we should. We tend to default to what's called heuristics, or simplifying what we see and assume what we do see is all that there is. And then we make decisions based on that. And so what he says is basically you need to leave the door open longer. So first part of the article was talking about, yes, patients come to us, they're uninformed. Second part of it is we're good decision makers, but probably not as good as we think we are. And that using a formal process to leave the door open to consider all the variables that could impact an outcome is important, especially in a complex environment like healthcare. And I guess related to that is that in medicine, there's probably 700 different risk assessment algorithms that are used to make predictions about different health outcomes. You know, what is a person's risk for having a stroke or a heart attack in the next 10 years? You can look that up. There's an algorithm for that. You can input the variables. They get confidence intervals on, you know, what your chances are, all sorts of things. In dentistry, we don't have those processes in place. And so one of the emphasis of that article was saying, hey, since patients are uninformed, since we're probably not as good at decision making as we think we are, that we should use a formal process to provide a better consent to patients, to provide a more grounded treatment plan and maintenance plan that's specific for that patient. So that's kind of a long-winded answer to your question about what was in that article. Basically, we need to be careful when we're making big ticket treatment decisions for patients, and implants oftentimes are. So,
I mean, humans are horrible decision makers. They always say, you know, when my kids would say, well, I got a gut feeling, I'd always say, well, your guts are filled with fecal matter, so I don't think that should come into being. I mean, what does fecal matter have to do with your decision? And the other thing I realized is we were born in an extremely Catholic family. My two older sisters, after high school, went straight to the nunnery. My oldest sister's a 61-year-old nun, and I couldn't change her mind one iota on Catholicism. And what's funny is I get older, every time the Pope over my 59 years has tried to make a reform, oh my gosh, they just go off the deep end. I remember when I was 10 years old and they switched the Mass from Latin to English. And my mom just thought it was the end of the world. And, you know, I used to enjoy it more when it was Latin because you could just sit there for an hour and meditate and think about your day and what you're going to do. And it really taught me how to just meditate for an hour a day. And when it went to English, it was like it was harder to think because you were paying attention and you know what they're saying. But I just think humans, they're just horrible decision makers. And half of everything they believe is fantasy. I mean, it's disconnected from reality. There's no physical observations for half of what people believe, and not just talking about religion, but even economics. I mean, I can't believe the economic policies that people with they really believe. So what is your approach to get dentists? I would have little faith in the old dentists, but the next generation of younger dentists, how do you think you can change them to be more data-driven in their thinking?
right. I think, you know, risk assessment tools in medicine, they call them diagnostic aids. And just a couple examples. If you're trying to calculate the risk of a person developing skin cancer, say melanoma, a dermatologist will look at a series of questions that they'll be asked. One would be, what was your natural hair color when you were 15? How many sunburns did you have growing up? What is the family history? Any history of melanoma? They'll put that into a formula, and then they'll determine what the risk is, and they'll establish what the recall should be for that individual based on what their risk is. But it's driven by data, and it's not their intuition or clinical judgment, which can be a supplement, but it's formalizing the process of determining, you know, what the recall should be, what a treatment plan should be, et cetera. So what I would like to see in dentistry for young people to consider is, yes, your intuition and clinical judgment will grow. It grows with, you know, learning from mistakes, and we all make in clinical dentistry mistakes every day of our clinical practice. But on certain decisions, we need to leave the door open longer and consider things. Like what we've proposed in an IJOMI article is for people that are treatment planning a patient with dental implants, that we should look at a host of variables. Let me back up. So implants are more vulnerable to biologic complications than our teeth. They with, high plaque values, with adjacent periodontal disease, with bruxism, they're more impacted by these comorbidities than our natural teeth. Also, that the incidence of peri-implantitis, or the equivalent of periodontal disease around implants, is much higher than people realize. It's about 12% by implant, or almost 20% by patient. And that's because a lot of patients have more than one implant. So after 7 years, about 20% of the patients that have implants will have bone loss around that. A lot of that's preventable. So since they're more vulnerable, we need to profile patients more. We need to look at the aggregate impacts of the various risks. And from the literature, what we've done is identified about 20 different risk factors that can impact, initiate, or perpetuate peri-implantitis. They include things like smoking, with subscales of how much they smoke, diabetes with subscales for what their glycemic control is. If it's above 8, you don't do implants. If it's 6.5 or less, you're pretty much clear, etc. And it includes things from history, things from the clinical exam, and things from decisions we make as clinicians. So what you can do, because implants are vulnerable, and because there's a lot of variability in how people respond to implants, we profile them by establishing an aggregate risk that the patient has for bone loss around their dental implants. So we look at things related to their history, to the clinical exam. And the clinical exam would be, do they have periodontal disease? Are they being treated for the periodontal disease? Is it severe? Is it moderate? Is it mild? You look at bruxism. Are there big facets on the teeth? If there's lots of facets, there's active periodontal disease. You better stabilize things, better think about a night guard in the treatment plan, because implants are impacted by those factors. And then the decisions you make. Are you going to use a bone level? Are you going to use a tissue level implant? All those things can impact what the aggregate risk that a patient has is. So I guess your question was, what take-home message to the young people is be willing to use processes as diagnostic aids in decision-making, especially when the decisions are complex and impactful. And a lot of the things we do in implants are. Be willing to leave the door open to peripheral information longer than your intuition or just clinical judgment would deem necessary. And profile your patients. Really spend some time trying to find out if they're low risk, which you can get away with pretty much anything, or intermediate or high risk. And if they're high risk, then you've got to have them on a more frequent recall system. You probably need more implants. There should be an effort at soft tissue conversion, more attached tissue around the individual implants, more access for cleaning. So some of these monster hybrid prostheses that people are learning to do, there should be ready access for cleaning, because those implants are more vulnerable and susceptible to failure. So, I mean, those are some of the take-home messages.
One of the problems is that I see for these young kids is they hear all these risk assessments. Like if I go to your mydentalrisk.com,
Right.
it asks if you're a patient or I'm a patient, I'm a doctor. What's the difference in the questions asking if you're risk for dental implant complications? Because they say don't do it for all these situations, but I'm out here in Arizona. The people that eat implants, I mean, they're not yoga instructors. They're smoking, drinking Irish. They throw their last cigarette out as they walk in the door and they're exhaling. I got one patient where every time he comes in, the staff's like, "Come on, John, exhale out the door before you walk in." So these young kids are like, okay, so what do you do when well, this guy's not a candidate for anything, but he wants implants. He doesn't like his loose denture.
Yeah, risk assessment is less about saying no than informing, and it's a
I love that.
detailed,
That was good.
patient-specific way to provide consent. So there's a whole bunch of articles.
Say that again slow. I'm a slow one. Risk assessment is more about informing the patient than saying no.
And it is saying no. Ideally, before you place implants, there will be information the patient is provided that outlines what their specific risks are, what their responsibilities are, and what the consequences could be. When I started doing this 10 years ago, I thought, oh my God, I'm going to lose patients. I'm going to scare them off. And I have to be careful how I say this, but I was so incredibly busy in my private practice. I saw only implant patients. I would see 14 implant patients a day. And it was fun. It was great. It helped me grow practice. I don't try and sell that part to use risk assessment for that reason, but patients are impressed when you at the beginning of the process, invest some time into discussing what their individual risks are, personalizing it, explaining how that impacts their responsibilities, what they can do. For example, if their HbA1c is 7.2, you could say, well, you can lower your point total and your overall risk from high to moderate if you can get a little bit better glycemic control. Before they plop down the $30,000 or $40,000 for their rehabilitation, they say, maybe I ought to invest in myself a little bit. So they get a little more compliant. They have a reason to, because they're investing a little bit of skin and dough into this. It's a good process. And what's interesting about consent process, think about yourself. The last time you were in to see a physician and we're going to have a minor procedure, in the consent form that was 10 pages long, you just skip to the back and you sign it. All the studies show people do not read, and when they try and read, they do not understand consent processes. They're a legal formality. They're not a way to inform a patient. So we're oftentimes having patients sign things, say with dental implants, but patients really don't understand what's going on. And the studies show they're usually afraid to ask. But if you go through this process, you're grounded and you're grounding them. You're grounding them into, again, what their patient-specific individual risks are. And it takes about 5 minutes. So we have that one website I made available to you. We've got another one that I should have released in the next couple weeks. It's been on the back burner. I just got to get off it. So the one you're talking about is mydentalrisk.com. We've got another one that has downloadable forms for patients and for clinicians, that it's a little checklist. You can hand it to them as part of the health questionnaire. They just check if they've got any of these little risks. You can review it with them. It adds just a few minutes. It invites the discussion and the dialogue Because what I was finding in my private practice is so often I would have a discussion with the patient. Yeah, you're a good candidate for dental implants. Let's do them. You're a little bit of a bruxer and your glycemic control isn't perfect, but I think we'll be just fine. And these are like professors at Berkeley where, I practice one block away from the campus. And then 7 or 8 years later, I'd say, we've got some bone loss around this implant. They would have no recall of the conversation we had. So by formalizing it into a written process where you've got this and you hand them a copy of this, or they take it online, or you make a note that they've taken it online. So it can be done online. It can be done with a hard copy printed out. And it's something that they can take with them. They tell their friends come in because, wow, nobody else has ever done this. It's a win-win in my opinion.
So it says, MyDentalRisk.com is an educational tool intended for informational purposes only. It does not provide dental care or advice and does not replace a doctor's judgment. Sending your results does not establish a doctor-patient relationship. If you have questions or concerns about your health, talk to a doctor. My Dental Risk is not responsible for any damages or loss from our website. I want to get clear on the stats you said at the beginning. 1% of all cancers are sinus related and 4% are head and neck related. Is that what you said?
Yeah. Uh-huh.
Wow. And that will require a
for the standard of care for maxillary sinus tumors is a maxillectomy. And that's what a maxillofacial prosthodontist does.
And should we start calling all prosthodontics maxillofacial prosthodontics? I mean, is that
only a small fraction of the people after their formal prosthodontic training get the additional training in maxillofacial prosthodontics.
Wow. And then the second thing I wanted to say, you're saying, is this good enough to say to you? I don't want to post something on Dental Town that's not right. Risk assessment, mydentalrisk.com, is about informing the patient, not about saying no and denying the patient's right for dental treatment. If you're a smoker and want implants, as long as you understand the risk, we're good to go. Is that a fair assessment?
Absolutely. It's about showing them on the continuum where they are, what they would need to do to decrease their risk, because not all, but a lot of the risk factors are modifiable, like smoking, like diabetes. And the studies show that if you can even decrease smoking from a pack a day, 20 down to 10, your risk goes down substantially. There's 2 articles in the last 6 months that show that very conclusively. So it's a dose effect on a lot of these things.
So smoking is really that dose related?
Yeah. And they have in studies where it was very conflicting, and people are going around the country saying, well, there's nothing conclusive saying that smoking is all that bad for dental implants. And it's because they cite studies that ask the binary question, do you smoke, not smoke? And if you smoke and you're smoking 5 cigarettes a day, it's very little impact. But you've got to look at the impacted dose.
So back to your mydentalrisk.com. Do you already have the website link for the one that's going to be done?
I do have it. We have the domain name. It's my dental risk advisor, but it's not operational yet.
So email me the link, howard@dentaltown.com, when it's done.
I will. And it's going to be good because it'll have, pretty good explanations, and it'll be a portal for patients and for clinicians, downloadable forms of the 20 risk factors, and you can just stick your logo or whatever you want on. There's no commercial interests in it. It's all, we're just doing it. I'm excited about it.
Back to that, mydentalrisk.com. Why does it divide you into 2 groups? I'm a patient, I'm a doctor. When you say I'm a doctor, Is
Yeah.
that,
We use
and the
different
first
jargon.
question is, does the patient smoke? And then I'm going to say yes, so you can see the next questions: 1 to 5 cigarettes a day, 6 to 20 cigarettes a day, 21 cigarettes a day. Does the patient have diabetes? I'm just going to say yes. What is his or her HbA1c at planned time of placement? 5.7 to 7, 7 to 8, greater than 8. I'll say greater than 8. Has an implant failed in the same site where another is to be placed? I'll say yes. Has the patient taken a bisphosphonate or other anti-resorptive medication? I'll say yes. What type of anti-resorptive medication? I'll say oral. And does the patient take a SSR1 medication? That's for depression, right?
Yeah, SSRIs.
I'll say yeah. Do they take a proton pump inhibitor? I'm just trying to spell it. Does the patient have a history of greater than 55 GY radiation of the head and neck? Does the patient have periodontal disease? I just keep saying yes. Periodontal disease diagnosis, aggressive. What is the current state of the aggressive periodontics? Treated and untreated and or active. Is the patient a Bruxer? I'll say yes. Is the implant being placed in the maxillary posterior? I'll say yes. In styrofoam. What were the patient's plaque levels when he or she first presented? I say heavy. What is the patient's gingival biotype? What's better, thick or thin?
Thick is much better.
Okay, explain that one. You
well-
stumped me
well-
on that one.
So when I went to dental school, that was never thought about or discussed. But basically, people that have thin tissue also have thin bone. And with trauma, there's much more recession. Recession, when you're doing crown and bridge on anterior teeth, especially, and it's a real thin tissue, delicate tissue, oftentimes more triangular teeth. And it's defined by if you can take an Explorer with a yellow tip, put it up into the sulcus, and have the patient smile. And if you can see through the tissue, it's a thin tissue phenotype. And those people will get much more recession if you traumatize that tissue with your provisional, implant provisional, or during the impression. So you basically need to be more careful with thin tissue patients.
That patient that we just sent in, it said, I submitted it. This blew my mind. It said that this patient is an extremely high risk. Dental implants not recommended. Contact your dentist, prosthodontist, or periodontist, or oral surgeon to discuss what these risks mean. That is really, really cool that you got there. So again, you believe that the patient has the right to spend their money on what treatment. I'm a big believer in this. Are you, that they have the right to do this?
Absolutely. And I see that all the time. So I'm going to give you a clinical example. Somebody I treated 8 or 10 years ago. I knew a little bit about this, but the literature that we're describing has only been out in the last 2 or 3 years. We didn't have this kind of detail or this kind of background information 3 years ago. But 8 years ago, I treated this one partially edentulous patient who'd been wearing a partial and hated it with implants, and he loved them. But at that time, I knew he had poor glycemic control. He was taking an SSRI. He was taking a proton pump inhibitor, and those are both risks that we can talk about why they're risks if you want to a little bit later. But over an 8-year period, he slowly got more and more bone loss, and he last year lost 3 of his 4 implants and came back in to see me. He had been regular recalls, and despite that, and he says, you know what? I'm ready for some bone grafting and more implants because I just want to avoid that partial denture. But I appreciate knowing why they're failing and what the risks are, so we can preserve the implants as long as possible. So I don't do any fewer implants because of risk assessment. I just have more informed patients, and I get less pushback when they forget if something does go wrong, because sometimes it's not that clear that something might go wrong. So yeah, so that risk assessment, and you talked about SSRI. I think that's worth talking about, those selective serotonin reuptake inhibitors. So especially now with COVID, the uncertainty, the anxiety at all-time high levels, public health experts are saying is there's more people on SSRIs than ever before, and that, you know, affects serotonin reuptake, but it also affects general bone metabolism. So it does impact how well dental implants work. So do proton pump inhibitors, which, with GI upset, it also impacts bone metabolism. SSRIs are interesting too, because 20% of the people that are taking an SSRI have a side effect from the SSRI, which is developing bruxism. So let's just say you have a patient, you've done 3 or 4 implants. The patient isn't taking any meds, but due to all this COVID, anxiety, et cetera, goes in, gets prescribed an SSRI. And 1 in 10 people in the United States at some point in their life will be treated for depression, right? So there are a lot of people, many millions of people taking proton pump inhibitors and SSRIs. Nexium for proton pump inhibitors is there's about an $8 billion a year industry. So they're pervasive and impactful on implants. So anyway, coming back to the SSRI, about 20% of the people that get an SSRI will develop bruxism. So all of a sudden, patients doing fine, they've got their implants, maybe they had a few little risk factors that were subclinical, then they start taking the SSRI, and they start bruxing. And with the bruxing, they initiate some problems with their implants. So this risk assessment is something you can use initially prior to placing implants. It's something you can review with the patient at recall visits. And when you go over this ahead of placing implants, and then you make recommendations, even if it's every 2 to 3 months for coming in for cleanings, they never miss their appointments. You've invested early, you've explained why, you've shown them what their risk profile is, and they do not miss appointments. And they tell their friends. So that's kind of my selling points to, we all have the realities of running a business, and this will not work against you.
Well, to me, I don't ever want to talk about religion, sex, politics, violence, any of that stuff. But for me, it's always been a problem with, I guess, authority from the government. I mean, when I read 5,000 years of history, I can't see any argument for the government's there for you. Like the person I bought my house from, she had brain cancer, and an American pharmaceutical company had a drug, and it was under the FDA approval process, and the FDA said, well, it's not approved, so you can have it. She's like, well, can I get on the test? No, there's no, you can't get on the deal. So she had to sell her house to me and move to Denmark because their hospitals were already selling it. And I thought, she was born in America. This drug was invented in America, made in America, and she has to leave her country to get a pill when she has brain cancer. She has the disease that this is being treated. And that's the line that I draw in the sand. It's the same thing when I listen to Noam Chomsky, who's down the street here in Tucson. He talks about that, the first time they use the word socialism is that the workers knew that the king was going to come by and steal half his crop in taxes. But when they said, no, we're also going to take your land, now he's a landless squatter peasant, and they're going to steal half, that socialism was first used as, I want to own my means of production. And I just think, and I asked Senator McCain that long time ago. I told him, I said, we have these Indian reservations, you legalize casinos, why don't you have an FDA-free zone right here by Arizona, Mayo Clinic, all these hospitals, and people who have the right to just go and be a guinea pig. I mean, they're going to die. Why are you doing it on a rat or a monkey? And the laugh he gave was like, it was like, I just didn't even understand how entrenched the system was. But I think it's all about individual rights. I think if I had brain cancer and you had discovered a drug and you were experimenting on monkeys and mice. And I'm like, dude, I got this. They said I'll be dead in 6 months. I have the right to do this. And that's what you're saying. You're saying you have the right to get implants if you smoke a pack a day, have diabetes, have gum disease, don't floss, because you just want to look prettier for that girl, 3 doors down. You have the right. And that's what really upsets a lot of people, is when other people take their rights away because supposedly, well, since they went to college and have a PhD and you're just from Kansas, you don't have the right. And we just need to get back to individual rights. And I like this. I'd want to be informed. I just don't want to be controlled.
Right. And by extension, it goes to all age groups. So I still do a fair number of implants in 90-plus-year-olds. It used to be thought that, hey, the really elderly, maybe we wouldn't get the value from implants. But I've done dozens and dozens of implants in 90-plus-year-olds. And uniformly, even when they only live 2 years longer, they've said, hey, this was of benefit. I'm glad I had this done. So I agree. I mean, the risk assessment is to ground yourself and to ground the patient in the realities, and just so they're aware of what's going on. It's not, and it's an aid. It's a diagnostic aid. Ultimately, it's the clinician and the patient, and it's closer to what we call shared decision making. Most of us listening were trained in dental school to do what's called informed decision making, where we inform ourselves, we evaluate a patient, we inform them of what we think they need and how things should be. The new model, and the model every Kaiser Northern California doc has to take, is how to do shared decision making, where you're, as a clinician, a neutral arbitrator of information without telling them what you necessarily think is best, at least at the beginning. You'll say, okay, you have a few missing teeth. We could do nothing, following what's called shortened dental arch. We could do a partial denture. Partial dentures increase chewing efficiency, but they also increase plaque accumulation by 35%. So you'd have to have better oral hygiene. You get more cavities on the guide planes and the rest seats. You have to be especially careful with that high fluoride toothpaste. We could do implants. We could do, on this side where it's tooth-borne, we could do a fixed bridge, but that increases the risk of cavities to those abutment teeth by about 5 times. So you outline, and so they know what all the risks are, they know what all the benefits are, and it's an informed decision-making process. And I agree 100% with you. We, as healthcare professionals, need to provide that information, inform the patients, and let them ultimately decide whether it's a cancer drug or a dental prosthesis. Giving them the choice and outline the possibilities is what we do. And I think that's what we try and do with this risk assessment questionnaire. So
one of the things I found most interesting about your risk assessment is it's not what you're doing, it's what you're not saying, is you never asked what type of implant it was. And a lot of these kids out here in Arizona, they don't understand, because you take a big company like Danaher, who spun off their dental division called Invista. They have 2 implant companies. They have the high cost Noble Biocare. They have Implants Direct, and they bought Neodent, the value Southwest Airlines implant out of Brazil. And lots of kids are asking, I mean, is there a reason I should buy the $500 implant instead of the $250 implant?
I mean,
and you never asked that question, and you're the stud on this dental implant risk assessment.
It's a good question, and there probably are differences. And there's probably differences in how well different implant systems work depending on the risk factors that a patient has. So, we're looking at a lot of those things. In other words, a person who's at very high risk may do much better with tissue level implants. A person with very thin tissue phenotype very little attached tissue may do better with tissue level rather than bone level implants. Overall, yeah, there's 700 different manufacturers of dental implants.
700?
Yeah, they're all have little niches that define their small little variation, either micro threads or different levels of roughness, and they're changing. And the thing we had when we debated this, there's a large group, had the president of AAP, American Academy of Perio, in the group, the Delphi group, where we debated what are the risk factors. And so you're asking a very good question. Why wasn't implant type put in there? We went over that for hours and hours and hours. And there is some evidence showing benefit to certain types of implants. But if you stick with one of the top 10, most of those companies are becoming more similar in design features than less similar.
And that's what you'd expect. I remember when Chrysler, Lee Iacocca came out with the minivan. He only had that exclusion for 1 year, and the next year, all 11 car companies around the world had a minivan. Right. So that's what you're saying, that if someone comes out with a minivan and implants and they really figure out something really, really cool and everyone loves it, well, the next year, the top 10 will have it.
Yeah. No, that's right. And I think probably underemphasized of all those risk factors is the impact of the clinician. And not talked about enough is there's really overwhelming evidence that the inexperienced clinician is oftentimes much more responsible for adverse outcomes than we care to acknowledge. And I think what's good, there's a lot of us that place a few implants surgically, but not always in high-risk patients. So let's just say we use the risk assessment questionnaire and the patient's at higher risk. We probably would want to refer that patient out to somebody who does surgery all day, every day, because the studies show they have better outcomes. So a person smoking, even 10 cigarettes a day, complications from the surgery itself double. Okay? This going through this risk assessment outcome algorithm will help you identify those higher risk patients, so you'll know to make the right choice on which patients to treat and which to refer. Doesn't mean they won't get it, but that means you might not do the surgery on every single patient, or if you do, the patient will be aware of what those risks are and why.
I remember I had the great luck and fortune to podcast Carl Misch before he passed away. And I'd known him for years, but man, when you're on your deathbed, it's a no holds barred conversation. I mean, he didn't care about offending anyone. And he was talking about, that was his schism with his brother, Craig, who's an implantologist in Florida. Carl would place an implant in smokers thinking, well, it's your call. And his brother Craig's like, I don't even want to mess with it. If you're not willing to smoke for implants, that's cool. Go to my brother. But he wouldn't do it. But the one thing Carl said that sounds so much like you, as he was saying that there's just no evidence for so many of the things we do in implantology. Like, he was not a big fan of drawing blood and spinning platelets and all that stuff like that. He said he wished everybody, instead of doing that, would just take the same time and do research on it. He goes, show me the research. And he basically said on that podcast, I mean, it's like an hour and a half, 2 hours long, that there's still a lot of voodoo going on. And I also noticed that, remember back in the day when they came out with that caries risk assessment? What was that called? What was the big one that California got behind?
Canberra and John Featherstone.
Canberra.
Yeah, and I could send you the 2010 article I did with him where we applied it to prosthodontic patients.
Oh, I would love it. But I
would love to see that get out, because that is a forerunner of risk assessment. Again, in medicine, there's maybe 700 developed risk assessment tools for different health outcomes. In dentistry, following the formal processes that are defined in risk assessment books, there's less than a handful, and they're not very well done. And so what we're talking about today is a decent start. There's a lot of things missing. In the more developed ones, that what they do is they look at what's additive. We're just looking at additive. There's certain things that would be subtractive. Like with peri-implantitis, we're looking at risk for bone loss, but certain things would be subtractive, like how often a person comes in and gets their implants cleaned would be subtractive. In the more sophisticated medical algorithms to establish risk for a health outcome, they put the additive and the subtractive and the synergistic. An example of a synergistic one would be if you have a patient who's a smoker and needs bone grafting, there's good evidence that that's synergistic, that that's more than just the additive risks of smoking and bone loss. It's synergistic. It's a multiplier effect. So risk assessment is by Carey's risk assessment with Featherstone was very, very early on. Ours is not very sophisticated, but there's room for many more layers of sophistication to be added to risk assessment to make it a more valuable tool. And my hope is dentistry will move towards that.
Yeah, because it makes so much sense. But did it really take off, the Carey's risk assessment? I mean, or it seems like people it seems like a lot of dentists would just diagnose everyone the same. Like if you're a kid, you need sealants, if et cetera, et cetera. Well, let's talk about that, because that's one that's always bothered me a lot. Sealants, your acid etching pits and fissures filled with cookies, crumb, plaque, all this crap. And then when I look at the research, well, it looks clearly that after a year, at least 40% of them are failed. At 2 years, they're almost all chipped, failed, fractured. But if you took microabrasion and sprayed out those pits and fissures, it goes all the way to the dentin every time. And then if you place an occlusal composite after spraying it all out, then it's a preventative resin restoration. But most pediatric dentists I know are still doing sealants, and I just show me some research about this sealant where half of them are gone in a year and they're all gone in 2 years. How does that play into their mind?
Well, I can tell you for sure you know more about this than I do. So
I doubt it.
I better not go there. I mean, I can tell you there are studies from John Featherstone and a number of others at UCSF that show using the risk assessment model, both in clinics and in private practice settings, is a benefit. There's a large funded NIH, NIDCR funded study at UCSF that looks at Cambra in children and shows, processes and protocols do decrease poor outcomes, do decrease disease. It's an imperfect system. And, again, with the sealants, I think you know much more about it than I do. But in adults, especially the geriatric population, for example, varnishes, the 22,000 parts per million, applying that 4 times a year on exposed root surfaces is huge. The diagnostic tools that are coming out are really exciting. And there's another area that UCSF is pioneering. Optical coherence tomography is basically sonar to show where the cavities are. That technology is taking off because ophthalmologists are using it so much, and it's a multi-billion-dollar a year industry. So we just take that developing technology and apply it to the oral cavity. And in not too many years in the future, you know how we scan, say, a lower arch with conventional digital scanning? We'll be able to scan a lower arch with this sonar optical coherence tomography and get a map of areas that are demineralized, slightly demineralized, and remineralized, and be able to say, hey, this patient needs this kind of solution of fluoride, calcium, phosphorus, et cetera, and be able to prevent a lot of cavities. So, I mean, I think that's where we're going. Some of those things are really exciting. Dan Freed is doing some incredible work with OCT. So Canberra is a start, and risk assessment as a formal process, I think will be easier to do when our diagnostics get a little bit better. But I think it is still a low-hanging fruit. We can make better decisions if we use diagnostic aids, if we use checklists, etc. One of my friends, just real quick story, pre-pandemic, I gave this lecture in Europe to a group about risk assessment, about why you need to use this process to ground yourself and to ground the patient and what the risks and responsibilities are with dental implants. And he came up to me afterwards and he says, Don, I have a busy practice. I'm making a lot of money. My patients are happy. I don't see that many failures. Why do I need to bother with risk assessment? Everything's working. Don't ruin my day. So I said, okay. And I forgot. I didn't think of this to say then, but later I thought, okay, John, tomorrow morning you're climbing on that 747 and you're going to fly 10 hours to San Francisco. And the pilot's probably done that same plane 5,000 times, but he's going to go through a checklist, right? To make sure he didn't miss anything. It's because it's a high stakes decision, right? It's not because he's not smart. It's not because he doesn't know that plane. It's because he wants to be sure. And I said, do you want him to blow off that checklist, that risk assessment, protocol, or do you want him to look at that? And that's what we're talking about here is just being willing to recognize that we're not perfect in our decision making. We come to the table, and so do patients, with what's called an optimism bias. The best book on that is Tali Sharot. It's called The Optimism Bias. And basically, one of the examples she uses, if I tell everybody in the group listening that you have a 23% chance of dying of cancer, that's the statistical certainty. And then I say, what is your individual risk? Over 90% of you will say your risk is less than 23%, which is impossible. But it's because we're optimistic about our future. Patients come in the same way. And yeah, optimism is good. It predicts, all sorts of success, it persistence, all sorts of favorable attributes. But in treatment planning, if there's optimism bias by the patient and the clinician, it becomes unrealistic. And a risk assessment questionnaire or a checklist brings you down. So the pilot, for example, won't dismiss this little cue, this little light that says, warning or this or that. That's what it's all about.
I see this at home. I mean, I got my 82-year-old mother. I just talked to her, this morning, and she's 82, and she's more worried about the risk of the coronavirus vaccine. I mean, she's in Wichita, Kansas. She goes all these church functions 3 times a week. She's just, and she's more worried about the risk of the vaccine being a problem than her catching coronavirus. And I just can't believe it. It's crazy.
Yeah. I mean,
oh, by the way, I have to ask you, sorry for personal information, but I have to ask, everyone wants me to ask, would you take the vaccine? On Dental Town, there's a thread 8 miles long called my staff won't take the vaccine. And young dentist, I mean, a lot of, I can give you the names of so many townies that are under 35, and they're like, well, I'm young and healthy. I mean, this isn't a concern for me. I want to see how this vaccine, what the long-term effects are and all that stuff. But they're doctors with 8 years of college, and they don't want to take the vaccine. So my question to you is, would you take the vaccine?
Well, I already have. I've had both doses. I had some side effects. Less than with the zoster. So I want everybody who doesn't believe in vaccines to just Google, what are the predictors of longevity? And it should come up. Everybody thinks either diet, exercise, this lifestyle or that lifestyle. the number one evidence-based is vaccines. If you get your vaccines, and that's science. That's the data. And this falls into that category. And I don't see any reason to doubt that. So I understand the trepidation, especially in certain communities where those communities have been maybe even experimented on. But boy, the science is firmly in the camp of getting a vaccine.
Are you talking about the 2014 study, Predictors of Exceptional Longevity, Effects of Early Childhood Conditions, Middle Environment, and Parental? Was there a certain...
I can look it up, but I just, I haven't, I don't know what comes up. I mean, there's books on the blue zone, looking at Okinawa, looking at Loma Linda, looking at the 7 or 8 different areas in the world where people tend to live longer. But of the things we can do, vaccines is number one. I can find an article that will say that. If it's not coming up, I can look for that. I'll tell you another interesting thing, since we're talking about just lifestyle and longevity things, is one of the things that will also come up. And when they dig down on why people in Okinawa live so long, they don't have a word for retirement. They call it just moving from one passion to another. In other words, you may formally stop this part of your development, but you just use that as an opportunity to transition to something else. You have to have something bigger than yourself to believe in. And I thought that was really interesting, since we're getting off the topic anyway.
No, I just found that study said vaccines, new opportunities for new societies. Vaccination is the most effective medical intervention ever introduced, and together with clean water and sanitation, it has eliminated a large part of the infectious diseases that once killed millions. And it goes on to talk about how it saved like 40 million people in the United States alone. The only thing I don't like about the clean water and sanitation is I spent my childhood, I had to wake up in the morning, I'd hear roosters, but now you can't have chickens and roosters and all that stuff because of their sanitation concerns. So yeah, we get to live longer, but we lost our pets. The article you're talking about with Featherstone, was that the
there's 2010 article I wrote for prosthodontics, and what it does is it just outlines the risks. Patients comes in missing a tooth, and you're trying to decide, should I do a fixed bridge? So you do a basic caries risk, and say the patient's at high risk for caries because they've had 3 or more cavity or a cavity in the last 3 years. They have a habit of only brushing once a day. They're not very good. Their plaque scores are high. Their dexterity's not so great. Their motivation's not so great. Their recall's not so great. You wouldn't want to do a fixed bridge, because those abutments for a fixed bridge, for example, are about 5 times higher risk for caries than single unit crowns. Okay. And I mentioned that a couple times because it's just not all that well known. So in that paper, we outline partially edentulous patients. What are you going to do? A bridge, maybe. If they're a low caries risk, yeah. Let's just say a partial denture. Partial dentures do a good job of increasing chewing efficiency. They allow people to eat a greater variety of foods with more efficiency. They can keep up at Thanksgiving. They work pretty well, except distal extension partials, where there's no back tooth to hook onto. Those don't work nearly as well. So all partials aren't created equal. But partial dentures have downsides too. They're a huge nidus for plaque accumulation. They increase plaque scores on the natural dentition in that arch and in the opposing arch by 30%. So you're introducing risk for adverse outcomes with everything you do. Even composite restorations increase class 5, increased plaque accumulation. So if you have a non-carious cervical lesion, you don't want to always place a filling. It's sometimes better to say, okay, no more hard bristle toothbrush, more vertical, less abrasive toothpaste. You've got to measure your intervention with what risks the patient has. So that's the whole thing about risk assessment. So in that article, we talk about implants as well. Implants have a different set of risks than, say, a fixed bridge. A patient who's at real high caries risk, probably you can get more aggressive with and doesn't have other risks that make implants at high risk. You would be a little bit more aggressive in taking out compromised teeth and using implants. So those are some of the things that we talked about in that article with Featherstone.
Yeah, interesting man. So one of my things about prosthodontics that's kind of I wish they would change their focus is that, you go to any of these major meetings like the CDA, and of course, when it comes to prosthodontics, it's the all on 4, and that lecture guy packs the house. And then there's no lecture on the all on none. And when I stand up and say, hey, raise your hand if you've never done an all on 4, and the whole class raises their hand. And then I say, raise your hand if you've never done an all on none, a denture. And they all raise their hand. And it just seems like prosthodontics is going as fast as it can to all on 4, and avoiding the all on none. And then in that book you said about the Optimism book, I always found that when you go from teeth to all on 4, implant retained, they're so nitpicking on the prosthesis. But if you first just take them to a denture, so you take them from their teeth, all that, you've gone to a denture, now they've done that, and then 6 months later, whatever, you upgrade them to, some implant supported, their psychology is so much better. I mean, I can't say this enough to the kids, but you under-promise and over-deliver. You don't have to root canal when they say, well, am I going to have any pain afterwards? You don't say, nah, you'll be fine, because then you just set yourself up that you could be a failure. It could hurt like hell. But if you say, I always do it the opposite way. I say, well, oh my God, when this anesthetic wears off, I hope you have a gun in the house, because you're probably going to need it to shoot yourself. And then they get all big-eyed and bushy-tailed. Then they come running in the next morning and say, Dr. Fran, you're not going to believe this. It didn't even hurt. I took like 1 aspirin and I was fine. But you got to lower their expectations and beat it. Man, my God, I had a girl one time and she broke off her front tooth. She said, well, can you make it look just like the other one? And I said, well, God made the other one, and so far, no one has accused me of being God. So, I'm going to try my hardest. I love the challenge, but still not God. And then she's like, and they're all scared. And then you deliver this Empress crown with all this pretty stuff that you learned at LVI and Ivoclar and all that stuff. And then she sees that and she just jumps out of the chair because she was expecting it to be worse, and I beat it. And I just see, especially with implants, every patient I know that gets a knee done or a hip or whatever, I'll say, well, how long did the doctor say that would last? They always say 5 years. And then all of the patients together, seems like they all last over 10. But the guys doing hips and knees, those guys are studs. They've got everybody to assume 5 years. It's a redo. And dentists are always like, oh, if we do this, it'll last forever. I'm like, really? I'm pretty sure the Earth's going to get engulfed by the sun. So forever is a mighty long time when you fall into the sun.
Yeah. My next door neighbor is an orthopedic surgeon. And so we have these talks, and managing patient expectations is huge. And in his reception room, he has a book on revisions. It's titled Revisions. They don't call them failures. They call them revisions. So when he does a hip or a knee, and 5 years into it or 2 years into it or 6 months because of a complication, they need to do something more, it's revisions. So he can show them in the book what needs to be done, and it's called revisions. That's part of the issue. And that comes back full circle to what we started with. Patients in the social media hear all the stuff. If you Google dental implants, you will get advertisements that promise everything, promise the world, the smile, the confidence, all this stuff. And it's not realistic. It can be that way for some low-risk groups, but it's not going to be that way for all the groups. And that's why it's important to profile your patients with risk assessments, so you know what group you're dealing with, so you can customize and manage patient expectations. So, and I think we have a little bit oversold. So one of the things I occasionally get involved with are malpractice cases. And I do this only because I want to pull us back a little bit from taking out as many healthy teeth. And one I can only describe in very general terms, but a 34-year-old woman with 27 or 28 teeth, no periodontal disease, no problem, good alignment, had 2 chipped front teeth, went into a place and had all the teeth taken out and all implants put in, upper and lower. And yes, she signed all the consent forms, but we have to be careful about managing expectations. That patient was psychologically unstable, and that's one where you would have to draw the line. Yes, you give them choice, and we talked about that earlier. And the reason I'm bringing this up is because there are times, yes, they have choice, but ultimately there are times you need to draw the line. So that patient went ahead with the implants, had all sorts of problems with the implants, and is in a very bad space now. So anyway, but managing expectations is really good. Occasionally saying no. Most of the time, just explaining to them what their risks are and motivating them to change the modifiable risk factors for whatever it is you're providing. And with dental implants, making them realize, hey, you've got to brush these. They aren't going to last forever for everybody. They may for some, but not for everybody. And to move yourself closer to that, you're going to need to brush more, to come in more often, to manage the perio condition in your existing adjacent teeth, all that kind of stuff.
So what percent would you say of implants placed today where you're out in Cali will need a revision versus will just need to be extracted?
Well, I mean, if you're going to look about what percentage of implants have a problem 7 years into it, and you look at the 2 largest systematic reviews, one by Lee and one by Rakic, and I can send you those, where each of them have about 45 or so articles, randomized controlled trials, retrospective studies, prospective studies, and they combine the data in what's called a meta-analysis. What percentage of patients that get dental implants will have a problem at 7 years? The number you can hang your hat on is about 12% will have peri-implantitis, significant bone loss after 7 years. That's by implant, and it's about 20%, 18.6% by patient, because a lot of the patients will have more than one implant. So what you do in those patients, the problem with dental implants is once the snowball starts, it's much more difficult to reverse it. I know all of us, when we were in dental school, we read the articles by Klaus Lang, where they took dental students from the 1970s and they said, don't brush your teeth for 3 weeks. And they chronicled all the steps of gingivitis. And then they said, okay, brush your teeth. And all 100% of those individuals reverse back to normal. If you get the initial stages of peri-implantitis, or the equivalent of periodontal disease around implants, and that's called peri-implant mucositis. There's been studies by Costa and all sorts of other people that even if you're in a maintenance program, about 20% of those will not reverse. So once you get the ball rolling with an inflammatory process around dental implants, a lot of times that won't reverse, which means your upfront maintenance program, your upfront risk assessment is probably even, and the fact that they're more vulnerable, the attachment around a dental implant is about 1/4 the structural integrity and resistance that the PDL and a connective tissue attachment offers around a natural tooth. So they're more vulnerable, and it's more difficult to stop the inflammatory process around implants than it is around teeth. Patients need to understand that in kind of a global terms, and clinicians should be explaining that to patients so they invite more compliance. If I tell a patient, hey, brush your teeth, you're going to get less periodontal disease, and brush them twice a day, and then they get up from the hygiene chair and they leave, they're going to remember that until they reach the stairs and they're gone. And the thought's gone. If I tell them with some evidence and data and implication, hey, look, your implants are more vulnerable than your teeth, and the attachment that forms around an implant is 4 times more vulnerable than the attachment around teeth. If you don't maintain this really carefully, you will get bone loss. And once you get bone loss around that implant, it's really, really hard to stop. So revisions are extremely difficult with the dental implant that gets peri-implantitis. It doesn't work very well. There's all sorts of wonder dusts and recipes for introducing things. I've been very unimpressed with everything from 20 years ago, Meffert, and Carl Misch. I remember being on programs with him. He would say the same thing, that it's once you get bone loss around dental implants, the downward trajectory is oftentimes troubling. Nisnek, who, I remember being in his office the years he was developing implants, his first implants, because I was down at USC at that point in the early 80s. When I talked to him about it, he says, Don, we can't stop that. All we need to do is take out the diseased implant and put in a new one. I totally disagree. I think we need to do much more proactive assessment of the patient, what their risks are and what they need to do to manage their implant. So, that's a long roundabout way of talking about revisions. What are the revisions? The revisions should be in our thinking. Revisions should be, there isn't as much we can do to an ailing implant, something that is losing bone. There's a lot more we can do proactively to avoid the bone loss process from starting. And then we would be able to do more implants and we would make more money, and there's nothing wrong with that.
So, are you a big fan of avoiding complications of an oral implantology do you think that would be a good book for the waiting room? Misch's Avoiding Complications in Implant Dentistry.
Yeah.
By Randall.
That is a good one. I would actually, the best, you want my opinion on the best book in implant dentistry?
Absolutely.
I think it's Steve Sadowski's book. I think it's called Evidence-Based Treatment Planning in Implant Dentistry. I hope that's right. I mean, I have to disclose that I know Steve pretty well and that I wrote a chapter in the book. I'm not making anything from this, and he's making very little, but it is a really good book. It talks about decision-making and when to keep it simple, like you said, with a complete denture, when to do 2 implants and an overdenture, when to do a zirconia, when to do a hybrid with acrylic and denture teeth, and a lot about how to do things. So all my students in the program read that book cover to cover.
Well, my gosh, you gotta promise me. I can't believe we've been over an hour, but you gotta send Mr. Stephen J. Sadowski. What's the J for? Is it John?
Yeah, I'll give you his phone number. You can give him a buzz. I'll give you his email, and you
Okay. Yeah.
email him.
Yeah. I'll email both of you. I got it. But evidence-based implant treatment planning and clinical protocols, first edition. Um, yeah, that would be that's an amazing book. So my gosh, those take so long to do. It's like having a child. Did you survive that book?
Yeah, I mean, I only wrote a chapter. What's interesting about Steve Sadowski, he was in private practice in Beverly Hills for 20 years, and then up in Washington for 20 years, 15 years, and didn't start academic career until he was 60. And then he's written a whole bunch of articles and I think the best textbook. So kudos to him to have, and I'm mentioning that because there may be other listeners that say, hey, I've explored the private practice routine. I want to jump into academics. Could I do it? And he's an example of somebody who did. And he didn't start until he was in his 60s. And he's, like I said, he got together a group of people and he wrote this book and he's done a whole bunch of articles. So he'd be great on this show.
Yeah. That is amazing. One last thing I want to do. I can't believe we went over an hour and our time's up. But the American Dental Association, they've added more specialties now. When I got out of school, there were 8, and now there's more specialties. If some kid was listening to you right now, a quarter of our listeners are still in dental kindergarten school, and some young kid is thinking about being just like you when they grow up, a prosthodontist. What do you think of the future of prosthodontics, and what would you tell that kid thinking about being a specialist like you?
Well, it's, I think, a great specialty. You get patients on a referral basis, have complex needs. Um, CODA standards are that we teach both implant placement and implant restoration, so it keeps things open as far as opportunities and variety. Um, Patients are so incredibly appreciative for the services you provide. I think the future of prosthodontics is very, very bright.
Well, that's and any it seems like fixed prosthodontics gets all the news as opposed to removable prosthodontics. Would you say that removable prosthodontics is the redheaded stepchild daughter of fixed?
Yeah, but it is also a very impactful process when you take the time and develop the expertise to arrange the teeth, select the teeth, get the right lip support, improve chewing efficiency. Removable prosthodontics can be incredibly impactful. I mean, people ask me, what's better, Don? You're 35 years in private practice or you're now full-time, academics? And I say, well, the highs and the lows were more dramatic in private practice, but UC is kind of muddling in the middle. I mean, an appreciative patient is the most significant reward for that a dentist can receive, because that is magical. And removable prosthodontics really allows you to do that for a lot of people. So fixed does get a lot more attention, but you're never going to be good at fixed until you're good at removable, because you've got to know the lip support. If you're going to do a zirconia full arch implant supported upper, you've got to know the incisal edge, how to keep the lip from inverting, how to optimize speech, how to position teeth for all the ideal speech sounds. So there's a lot that goes into the fixed that relies on the removable.
My gosh, you sound just like Carl. I remember when I was out here in '87, there was no dental schools, there was no water fluoridation, there was no dental schools in Nevada and Utah. And I was trying to get my FAGD, and I had to go take all these implant courses, and I went out to Pittsburgh because if I signed up, I didn't want to place implants at all. But if I signed up for the 7 3-day course, I could get all my requirements and I'd learn the didactics and all that thing. And that's what Carl said. His opening lecture was, I started in removable. And the only reason I got into implants is because I'd see these guys, these hacks, placing implants, and the implants would break or fail or whatever, and they'd always blame it on the implant. And he'd say, well, that's funny because you had the wrong bite. You did everything else wrong, but the implant's the failure. And he actually got into it because he mastered removable first. And that's what I love about, when you listen to these, I call them extremists in TMJ or ortho, when they're doing their TMJ debates, it's like, okay, what you're saying just tells me that you've never done one case of orthodontics. I mean, if you just did one ortho case, you couldn't believe that. So cross-training is everything. And even though these kids, my advice for these kids is this: it is getting to be a highly competitive world. I mean, Russia's saying right now that the country of Russia can't even compete with Elon Musk's SpaceX program. Now, who would have thought of that when you were growing up during the Cold War? But you kids, I don't care if you specialize or don't specialize, but my piece of advice is you got to get out of school and you got to get good on one thing. Get really, really good. It's like if you want to be a stand-up comedian, you need to get out on the road and get funny and play all those pubs. If you're a rock band, same thing. You start in these little pubs. I remember when I took my 4 boys to Green Day, and the first thing he said during that concert, he says, so what do you think? I just sold out America West Arena in Phoenix, Arizona, and everybody's screaming. He goes, is that badass or what? And everybody's screaming. He goes, well, let me tell you punk-ass kids a few things. Number one, this is the 19th year I've played in Phoenix. And the first 10, there wasn't 50 people in the room. And he starts naming all the little pubs. And he goes, it takes a long time to get good. And you're not going to write a song and sell out an arena. And that's why I tell these kids, you're going to come out of school, and you're not going to get it good at something you hate. But if you hate it, is it because it's really, really challenging? And just find something to hang your hat on where 10 years out of school, you're just really, really, really good at something. So just get out there and get your guitar and start playing and get good at something. And if you get good at something in healthcare, the fastest growing segment of the economy in the world. I mean, in 1900, it was 1% of the GDP. By 2000, healthcare was 12% of the GDP. Now it's only 2020 and it's 17% of the GDP. Obviously, any economist will tell you supply and demand, that if you're born and you got about 30,000 days to live, after you rip through 20,000 of these days, you're willing to spend a lot of your accumulated money to try to extend that last remaining day. And they just keep bidding up the price, and that's what the Mayo brothers figured out. The Mayo brothers figured out, like, oh my God, these people will spend their life savings just to extend their life one more year at the very end. So, healthcare is where it's at. I'd rather be in healthcare than coal. But if you're going to get in healthcare, you just need to get good. But it was just a huge honor for me. I was so excited this morning that I got to podcast you. And any of those studies that you were talking about sending me, you can email them to me, howard@dentaltown.com, or post them on that thread where I posted your survey, which is exploding. But thanks for all you do for dentistry, and you're a legend, and it was just an honor to interview you.
Well, thanks so much, and good luck to everybody. The future of dentistry is very bright. Develop that expertise and go out and work with patients and have fun.